Good afternoon. My name is Jessica Hubbard, and I'm the manager for Community Education Department here at MDA. We're thrilled to have you join us for today's SMA Q&A session and Drug Development Roundtable. This learning event is part of our larger MDA Community Education Program, which focuses on bringing the neuromuscular disease community together around education and resources. Excuse me. Be sure to visit Community Education section on mda.org for updates on upcoming events. We are recording today's event and we'll be posting it to our website for on-demand viewing at a later date. Please know that all phone lines have been muted, but you can still ask questions. We'll begin the Q&A session with the questions that you provided at registration. Feel free to type any questions into the chat and send them as you think of them as well. We would like to thank our sponsors, Genentech, Biogen, and Scholar Rock for supporting MDA's SMA virtual learning series and Q&A session. All right, for nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. MDA delivers this mission through research, care, advocacy, and engagement. And since its inception, MDA has invested more than $1.1 billion in neuromuscular disease research. MDA funds projects throughout the drug development process from early discovery through translational stages and infrastructure support for clinical trials. Our community education and recreation programs are designed to connect individuals and families. We are committed to building a nurturing environment where our members can share experiences, triumphs, and challenges. In 2023, we offered over 40 educational programs and over 20 summer camps and dozens of other community activities, both in person and virtually. If you haven't done so already, we invite you to join the MDA community by registering with us. Registering is free, and please see the link in the chat. To learn more about MDA, please visit mda.org. All right, now it is my pleasure to introduce today's Q&A session speakers. We have Dr. Ann Connolly, neurologist at Nationwide Children's Hospital in Columbus, Ohio, Dr. Jason Howard, pediatric orthopedic surgeon at Numerous Children's Hospital in Delaware, and Kara Arps, a board-certified pediatric clinical specialist at Monroe Children's Hospital at Vanderbilt. Our speakers should seem familiar to you as they presented in the recordings you received upon registration for this virtual learning series. We look forward to hearing from all three of you today. We will begin with questions from registration. Let's open it up, and then we will open it up to questions from the audience after we get through those. So the first question that we have is, we recently saw news around CRISPR and progeria. Could this be used in SMA? And so Dr. Connolly, I'll let you kind of begin with that. And then if Ms. Arps or Dr. Howard, have anything to add to that, then I will let them speak as well.
Yeah, so it's a great question. First of all, CRISPR is everywhere. It's being tested in animal models of virtually everything, including animal models potentially for SMA. The difference, the reason I don't think it's immediately going to be used in SMA is that the three things that are available right now are highly effective. And so using CRISPR when you have highly effective treatments, if given early, means it falls a little bit down on the critical list for CRISPR. But I am aware of the work in progeria and many other disorders, and the potentially exciting thing for those disorders is that if successful, CRISPR would allow the gene to be fixed so that future generations would not have that. I mean, that's the dream at the end of the day, but we are a long way from that right now.
Wonderful. Thank you so much. And Dr. Howard, I see that you are with us now. I apologize for that delay. Just to let you know what question was just asked, it was that we recently saw news around CRISPR and progeria, and would this be something that could be used in SMA? I don't know if you have anything you want to add to that, but Dr. Connolly, thank you for that thorough answer. Ms. Arps or Dr. Howard, would either
I
of you
think
like
I'll leave
to
it to
add
Dr.
anything?
Connolly.
Okay. All right. That sounds great. Thank you. All right. So our next question, and again, these came from registration whenever our participants registered for the seminar series. So the second question is, if an adult has rigid spine MD and never had therapy, such as OT or PT until their late 40s, and they are now non-ambulatory, can this be reversed? Dr. Howard, I'll let you go ahead and begin with that one if that's okay with you.
Yeah, I mean that's a tough one. I would say in my experience that the name of the syndrome is quite aptly named in that they do the patients would develop this spinal deformity, which does become quite stiff, and it's not likely to get better over time with just natural history. Typically requires some kind of surgical intervention to correct it. So unfortunately, I can't say that this gets better over time. In fact, it's most likely to get worse given the progressive nature of the disease, which is not spinal muscular atrophy. Of course, it's a completely different uh, diagnosis, and it's even more rare.
Thank you. That makes sense. Dr. Connolly, did you have anything that you would like to add, or Ms. Arps? Oh,
I
Dr. Connolly, I
completely
believe you're
agree.
muted. There
But
you are.
the one point I would make is with rigid spine, we typically think that your back is arched, and if your back is arched, the issue might be your neck is also arched, and then swallowing becomes difficult if it really keeps going. And so um, if somebody is already non-ambulatory, obviously the goal may not be to be ambulate, but the goal may be to give some degree of range of motion back to be able to swallow more safely. And what I always say to patients is, and their parents, quite honestly, tip your head way, way back and try to swallow. Very difficult. So I think there are few. We had one such child who had was just literally could not swallow, and there was some release because it's fibrous tissue. It's not, it's not really. It's just like you said. It's Dr. Howard said. It's the muscles, the tendons, everything is stiff and rigid. So surgical approach would be the only one, but the indication for it would be more like if it's impacting ability to swallow or even the ability to see sometimes if the neck gets put into a lot of extension. But again, not typical for SMA at all.
Okay. Thank you so much.
Both of those answers, but I would also add, I know you mentioned that I think you said there wasn't therapy experience in the past, and I don't anticipate therapy would be able to reverse any of the things that have progressed, but it might be worthwhile to engage with the therapist to help with positioning and to help to prevent any additional complications that would result from the underlying diagnosis. So that might still be a worthwhile referral and interaction to be able to support equipment and positioning needs.
Yeah, no, and that's a great point that even though it wasn't received prior to that, seeking that therapy even later on could still be beneficial. Thank you so much for that input. Let's see, our next one, and this is more of a not sure that there is a yes or no or a black or white answer, but I did want to share the question and just see if you guys have anything to add to this one. It is, will medical science or technology ever be available that would enable my wife to transfer herself again? So kind of along the same as the last question, and kind of reversal. Is there anything on the horizon or anything that you guys have seen or heard of that could answer this question?
I can take the first shot and then my colleagues will certainly jump in.
Thank
So,
you, Connolly.
so the interesting thing about transferring, so this is, we don't know the exact details, but the point is that transferring, that for independent transferring, really, if you think about the easiest way to do it is we all stand up, we turn over, and we sit down. Well, that requires leg and arm strength. Okay, so if you don't have the leg strength, then it requires a lot of shoulder strength. You have to actually be able to, I'm sitting in a chair, obviously, so you have to be able to push yourself up and over. Well, if you do that, that is shoulder strength. So regaining shoulder strength in SMA, or trying to get some shoulder strength back, is one of the studies. That question is being studied. We don't have the answer yet, but it's being studied in two different studies. And I think both of them I probably mentioned in my talk, but one is, they're both monoclonal antibodies. One is given by just subcutaneous injection. One is given through a monthly IV infusion. But in both cases, what they're attempting to do is to increase the amount of muscle you do have. Now, if your wife has no muscle, and that happens in SMA as well, in other words, if all muscle is gone, then the answer would be no. But I would also say that, we're getting more and more clever with technical devices. And this is where I will defer to my colleagues, but technical devices that, maybe you can push a button and have somebody open the refrigerator, get out milk. You can, but transfers are, a huge impact on quality of life. And in SMA, one of the reasons it used to be called proximal SMA is because it always hit those big proximal muscles first.
Thank you so much, Dr. Connolly. Dr. Howard or Ms. Arps, would you guys like to add anything?
I mean, I would probably just go along the technology front. I'm an orthopedic surgeon, and my goal in treating people with SMA is mobility, and not just walking, but transfers, and also to make sure that they have comfortable seating and are free of pain in their joints. But transferring when you have that weakness in the upper limbs, like as Ann said, it makes things problematic. From a technology point of view, at the Moores, we are working with some engineers at University of Pennsylvania who have developed a myoelectric type augments, which kind of clamp around the arms, now just really the biceps area and the forearm area, not so much to be able to get the strength to transfer you out of a chair, which I think would take a lot of shoulder activation, and that may be a problem for the reasons Dr. Connolly had mentioned, but more to be able to use the upper limbs for functional tasks otherwise. And that's shown some promise, although I think that we're still a little bit away from that. There has been some research in exoskeleton technologies for patients with paralytic disorders, which potentially could have some application in the future, and that's shown some promise. But as of something that we have right now off the shelf that we could offer, I wouldn't say that we have that available, though there are also other aspects related to motorized lifts and the like, which are becoming more sophisticated. And so I think there may be some exciting prospects coming down the pike on that.
Wow, that is all very exciting. Ms. Arps, did you have something as well?
I probably don't have a whole lot to add. I second most of that. I will, and obviously it's hard not knowing the exact circumstances of the situation, but I do agree from a technologic standpoint, there are some overhead lift systems now that do allow individuals who have some ability to help position components of the lift like beneath their legs to be able to use the lifts independently without having to use a full sling system. So technology is improving in that way, and depending on the strength they have in their arms to be able to position the lift equipment appropriately, that could be an option for them to do it independently. But again, we need to know a little bit more about the situation to provide
Right.
guidance.
Yeah.
But I think that is probably the way to go to pursue independence.
Yeah, well, and I think a key takeaway from that is technology is improving. So while there may not be, a certain answer now, it is improving regularly. So that's very promising. Our next question relates to exercise. So Ms. Arps, while I have you on, we'll go ahead and are there any specific exercises or physical therapies that can help maintain my joint health? So specific to joint health.
Yeah, absolutely. That's a great question. And I think it depends. My answer would depend a little bit on if we're assuming we're doing this with more active movement or with more passive movement. But either way, any kind of movement around the joint is going to be helpful for keeping the fluids moving, making sure we're keeping the capsule loose and keeping all of the joint, all the components of the joint loose. So if you're not able to do it independently, I would encourage having someone do more passive movement. And you participating through whatever active range you're able to do, and then having someone assist with the remainder of that. I think the second part of that is the hip joints are definitely an area that we want to be very aware of. And so if you are able to, and I would get clearance from your medical team before doing this, using a standing device, whether that be standing in a power chair or using a stander, is going to help significantly to get weight through your legs and to also help with maintaining the integrity of your hip joint. And so that can be another option to maintain the integrity there. Another great place to be able to have some more movement sometimes is in the water. That's a really nice place to be able to allow more freedom of movement that can help to keep those joints healthy as well. So that is always a good option.
Those are all great. Oh, go ahead. I was just going to say those are all great recommendations. Go ahead, Dr. Howard.
I was just going to add from a orthopedic surgeon perspective, respect to joint health. All of those things are very important. Help decrease contracture development and for comfortable seating, standing, walking if you're able. Those things are all important. One of the other things that maybe hasn't had as much press in the past as it has now recently is hip joint health. You mentioned it, Kara, but with respect to coming out of the joint, unstable, we're finding that it be a little bit more of a problem for patients with respect to increased joint forces when you're taking disease modifying agents like Zolgensma or nusinersen or whatnot. And from my perspective, I'm hearing more complaints about hip pain and degenerative arthritis. And so we've become more proactive now in doing radiographic surveillance of the hips to make sure that if hip is coming out of the joint, we have someone who has improving function on some of these agents, and we're anticipating we might run into problems and trying to prevent them. So, doing radiographic surveillance is an important part of that to kind of nip things in the bud before they get to a point where things like soft tissue releases or bony reconstructions or things like that, can still be utilized to help preserve that hip health for the long term.
Those are all really good points. Dr. Connolly, did you have anything you would like to add?
I just wanted to fully support my colleague there. The odd thing is with treatments, we are seeing, depending on when your child got the treatment, if they got it a little bit later, some of the muscle groups in the hips are stronger, but some of them are not. So that the child may be able to walk, but with a very modified gait. And having lived a very long time, it would remind me of somebody who was born with, say, a congenital dislocated hip that went unrecognized. Sure, they had developed the ability to walk, but the joint was never moving fully. And the only other comfort thing I'd say for people who cannot move their joints, that maybe they are weaker, in my experience, every one of those folks, even if they have limited shoulder movement, like passive range of motion through the joint, especially the ball and socket joints, the shoulders and the hips. And first thing in the morning, last thing at night, just getting some range of motion of the joint itself. I kind of call it lubricating the joint. It's not going to make the joint brand new, but it feels better. And that's a very simple thing for a caregiver to know.
Yeah, absolutely. Feeling better is a very important piece to overall well-being. So it's very important. Thank you, all three of you, for your answers on that one. Another one is about some kind of lab levels, but not specific, but just in general. If a creatine level is very low and they take a supplement already, but it doesn't increase the level, is there any way to increase that? Yes.
So
Dr. Connolly.
what you need to know is that mostly reflects muscle mass. So 100% of children with SMA who have not been dosed very early in their life have a low creatine. Taking extra creatine will not change that. Years ago, we said, well, maybe taking creatine will make the muscles they have stronger. It does not. It just is processed through the kidneys. So the low creatine is not in any way itself dangerous. It is a reflection of the total amount of muscle mass the person has.
That makes sense. So taking the supplement isn't necessarily going to change things there. Anything anyone else would like to add to that one? I mean, I think that was a pretty straightforward answer. Thank you for that, and very, very explanatory. All right, so I have another orthopedic question. From an orthopedic perspective, has any research been done to determine if bracing for scoliosis is beneficial?
Yeah, that's a question I get asked a lot, because scoliosis is so prevalent in spinal muscular atrophy. If you have type 1 or type 2 SMA, for example, your risk of getting scoliosis at some point during your lifetime is 88 to 90%, so pretty high. Type 3 would be lower, but still around 50%. So, so scoliosis is very prevalent, and you would think that early on, maybe applying a brace that straightens the spine and helps to keep your trunk more upright certainly can help for seating comfort. But unfortunately, everything we know to this point is really not really shown that bracing can prevent progression of scoliosis and prevention of a surgical intervention, if that's where things are heading. We do use braces, usually a soft type clamshell type brace, which allows for your belly to kind of help with your breathing. If you have a G tube, to allow for the G tube to have a place to go, and make sure you don't have too much pressure on your skin. But that's mostly for seating comfort when you have weak muscles around your trunk, but it's not for stopping curve progression. I would say though that there's not fantastic medical evidence which has looked at this extremely carefully, but of all of the neuromuscular diseases that I treat, from cerebral palsy to Duchenne to rigid spine syndrome, none of these diagnoses really have we found that using bracing has stopped the progression of a curve, a scoliosis curve. It's mostly based on growth, the severity of your muscle weakness and motor function deficits than it is to do with any external device. But the nice thing is, for people who do have that, we do have a treatment for it. It works very well, which is, spinal fusion surgery, which I do. And it's a very rewarding procedure because patients right away get the benefits of that. And with disease modifying agents now, it's much safer. The risks of surgery have decreased significantly. We've done some research looking at that. So I would say that if you get into some trouble with a scoliosis that progresses to the point where it's affecting your function and quality of life, then it's something to consider.
Yeah, and that's something you covered in great detail during your recording that we sent out as far as the surgery and how that works and everything. So hopefully, if our participants haven't had a chance to do that yet, hopefully they can go back and watch that and get some more details on what you're speaking to. But thank you. Does anyone have anything else to add to the question around the bracing? I think that was a pretty thorough answer. So thank you, Dr. Howard.
Finally, something I know something about.
Just add quickly from a therapy standpoint,
Absolutely.
I fully agree with all of that. I will say sometimes we will with especially younger patients, but sometimes older ones as well. If they have a soft TLSO, we will use that to help support other areas of strengthening. So we may use that to give them some support at the trunk so they can work on strengthening the muscles of the neck to work on head control. Or maybe we'll use it to give them some support at their core so we can get them into a weight-bearing position and quadruped on their hands and knees to get weight through their arms. So sometimes we will use them therapeutically as well, even though we know they're not going to be used alone to solely prevent a scoliosis progression.
Sure, and that makes sense. That it could be used for other reasons, not just for that prevention. Thank you for sharing. Let's see. I have another question on exercise. If I only have time and energy for a few exercises per day, what are the best ways to maintain mobility in my limbs? And I'm sure you guys all have something to give on this one, so I'll let you go ahead, Ms. Arps.
Yeah, that's a great question. I think we all experience limitations in time in the day, and we're all trying to prioritize our time the best way we can. I think my first answer to that would be trying to distribute your focus of those activities depending on the time you have. So, and again, this is going to be person dependent on what they're able to do. But if you have a 10 to 15 minutes a day, maybe you're alternating being able to do something that's a little bit more aerobic. And then on other days doing something that's a little bit more focused on strength. And so I think that would be the first thing I say is that both of those aspects are very important. And so even if you can't meet the ideal recommended frequency for both, at least trying to alternate them to get them both in, I think would be a good bet. The other thing I'll say is I think another good approach is to alternate parts of the body that you're targeting. So again, if you only have a few minutes, maybe one day you're doing some exercises for the legs, and then the next day you're doing some exercises for the arms, whether that be passively with someone assisting or doing some more active exercises. And so that can be another good approach. It's hard to give specific exercise recommendations without a little bit more information, but I would point you to a reference that's available on the MDA website that has a really good source of exercises for people of all different functional levels and talks through some both stretching exercises and then also some strengthening exercises that could be beneficial for all parts of the body. And that's available. It's called At-Home Physical Therapy Exercises for SMA, and it's available on the MDA website. So that would be a great resource.
Yes, absolutely. And we can share that in the chat as well so that, it can be easily accessed. But thank you for mentioning that. Dr. Howard or Dr. Connolly, did either of you have anything to add to if there's only a couple of exercises you could possibly do a day, what would you choose?
I mean, when I see people, sorry, go ahead.
No, go ahead. No, go ahead.
Dr. Connolly, you go. Okay. I was just going to say, when I see people in the clinic, I'm assessing their mobility of their joints and looking at the muscles that are typically become more tight. The hip adductors, the groin muscles, the hamstring muscles, the ankle, the calf muscles that put you up on your tiptoe and sometimes turn your foot over into a position that can become quite uncomfortable on your wheelchair foot plates if you use a wheelchair to ambulate. So I kind of think about, just like Ms. Arps said, if you don't have, it's hard to give you a specific recommendation without knowing your situation. I would concentrate on the things that are causing you the functional limitations and work on those. And once you kind of got those, into a place where things feel a little bit more limber and you feel a little more comfortable, then you can move on to some more general health type things. Other than those specific things, I would say try and find something that you enjoy doing, that also gets, the muscles moving, gets your heart pumping, and because you're more likely to do that more often than things that are a bit of a chore. Sometimes you need to do the chore part. But I would also say to not feel guilty about it if you're finding that things aren't moving the way you want them to, or say you have your foot that's turned in and you just can't twist it out despite everything you're doing. That's tough, and it's even the best rehabilitation you can do yourself at home or with professionals, these things still happen. So I wouldn't feel guilty about it, but keeping a regular routine is also a good thing. And there is help if you get to the point where you've done everything and you're still having problem with joint positioning and discomfort. And so we do help people with that, with sometimes some simple surgical lengthening, which can help quite a bit.
All very good points. Thank you, Dr. Howard. Dr. Connolly?
Yeah, I just had one small thing to add. We do know that if your muscle in SMA in general, if the muscle does work, you can use it. So if you have hand and arms, you can use it, and it will not hurt it. SMA, by and large, is not a major turnover disease like Duchenne and other dystrophies. So do use it. But my more important point, and this is especially if there are any parents on or something, the only exercise that is sustainable is one you enjoy. So I like to throw out, if you could only do one, it would be swimming. Because yes, it's not weight bearing and all of those things, but it allows you to use every joint, every muscle group to the best of that range of motion. So it's also for kids the great equalizer. They can be playing in a pool, but they cannot necessarily play in a soccer field. But lots of times parents are trying to get their kids to do little weight lifts, or, like the kid hates it. If the child hates it, then I get to be the good guy and say, no, we're not doing that. So
Yeah, those are
out there.
Those are excellent points, Dr. Connolly. I can attest to those as well. So definitely for my son, swimming is his happy place because he can, use all the muscles in its playtime, and he doesn't really even realize that it's an exercise. So all good points. Let's see. I believe we have and we have about 2 more questions, and then we'll probably wrap it up so we can move over to the drug development roundtable. I know we're a little off schedule, and I apologize, but I would like to get these last couple of questions in quickly. Let's see. What can be done to manage respiratory function that's been inhibited by scoliosis? Dr. Howard, I'll let you kind of start with this one since that's kind of in your wheelhouse, but what can be done to manage the respiratory function?
Thank you. That's another very common question we get. And actually, we've got a lot of referrals from pulmonologists, for example, who feel that we may have a role to help with pulmonary function. And I would say that, of the research we've done, though, on scoliosis and effect on pulmonary function, despite having scoliosis surgery, the pulmonary function still tends to deteriorate over time. in accordance, with the natural history of disease progression. I'm speaking now in the era before the onset of disease-modifying agents like Spinraza. Those agents have definitely changed the playing field, and we've seen after scoliosis surgery that respiratory function has stayed kind of stayed on the even keel and not deteriorated over about a 10-year period. So I think that's not just the scoliosis surgery itself, but probably more the medications that are making the impact. What the scoliosis surgery does is it gets you into a more upright position. It gets you better seating, better quality of life, and improved positioning. People feel they have a better use of of their upper limbs. Although sometimes if you have a lot of proximal muscle weakness in your shoulders, it can be difficult to do things like eating and things after scoliosis surgery. So there's other sort of things you have to keep in mind and devices you have to use to that. But from a pulmonary function, the effects on the respiratory function are probably not that significant. We have the intercostal muscles, the muscles around the ribs, which are getting weaker over time, which probably have a bigger impact on pulmonary function. And I think a lot of pulmonologists are coming to that realization as well. I did do a systematic review on this in the literature because I got so many people questions about it. We looked at all the literature, and that was the results of that. If you're looking for some good bedtime reading, you can look it up.
Yeah, sure. We'll add that to our list.
Or if you're insomniac, it can help for that.
Sure. And Ms. Arps, do you have anything to add, physical therapy or occupational therapy wise, for that respiratory function side of things?
Yeah, so I think it is important to consider that the muscles that help you breathe are in fact muscles and can also be trained like other muscles in the body. Depending on if the decreased capacity is more due to scoliosis, you're only going to have so much room for expansion, and so there's only so much room in which you can work on training those muscles. But there are activities that you can do to maintain the strength of those main pulmonary muscles, and then also what we call the accessory muscles, which are the extra muscles that help with multiple things in the body, one of which is helping to breathe. So for littler kids, even things as simple as having them spend some time blowing bubbles and practicing taking deep breaths in and blowing out can help to use those muscles. Or there's lots of little games you can do with straws and having them use a straw to blow different things. And for older individuals, you can do more formalized breathing programs, whether that's just practicing deep breathing or breathing against different devices that actually provide a little bit of resistance. There are ways that you can help to train those respiratory muscles to help maintain their strength. But ultimately, if it is more of a decrease due to the structural component of the scoliosis, you're going to be limited in how much progress you're going to make.
Sure, and that makes sense. Dr. Connolly, anything you would like to add to this question? I think you're muted, but I also believe I've read your body language.
She read my lips. I said, I think you hit it pretty well. For SMA, there is a tiny bit of literature that if you're quite weak, the BiPAP at night might actually improve your lung size and volume. So it forces you to take bigger breaths. And the only other kind of interesting ongoing thing that I'm watching in the SMA world is, the early use of magic rods to sort of grow the chest, if you will, in association with something that gives you a little bit of SMN back. So I feel like pulmonary function overall, since we've had disease-modifying agents, is better. But
Yeah, no, thank you for adding that. We are kind of running tight on time, so we're probably going to need to wrap up our Q&A session. But I do want to thank you, Dr. Connolly, Dr. Howard, and Ms. Arps for sharing your time, especially as delayed as we were today. I appreciate your patience and your time, as well as your expertise and everything that you guys do for the neuromuscular community. Thank you so much for being here today. And should some of our participants that weren't able to join us due to our technical difficulties, if they have any questions, I may compile them and send them out to see if you guys may be able to answer them at a later date offline. So just so that people know that if they weren't able to join us, they can still submit their questions to me, and I'll do my best to get those answered. But thank you guys so much for spending this last hour with us and answering all of the questions from our participants.
You're most welcome.
much.
Thanks very much.
Thank you,
Yeah.
guys. All right, so switching gears a little bit, let's give me a moment to get my bearings about me here.
So I get to leave, right?
You sure do. You guys are free to go unless you would like
Wait a minute,
to
did
stick
I not
around.
get?
You're welcome to stay, but you are free to go as well. Thank you so
okay.
much.
That's all right.
All right, let me get from here. Okay. Sorry, just a moment. Okay. All right. So we are going to move into our drug development roundtable. And we have the opportunity to hear from Dr. Kara Arps, which is Biogen's Medical Director of Rare Disease. Oh, I apologize. I've clicked through my screen too far. All right, I apologize for that. All right, so we have Dr. Kara Arps from Biogen. She's the Medical Director of Rare Disease. And we also will have Dr. Sharon Hesterly, which she is the Chief research officer here at MDA. And then we have Mindy Henderson, Vice President in Disability Outreach and Empowerment, and Editor-in-Chief of MDA's Quest magazine, or Quest Media. And they will be here, so welcome to all of you, and thank you so much for being here today. We're waiting on Dr. Hesterly. I'm not sure if she's going to be able to join us or not, but we're going to go ahead and get started with our drug development roundtable. So I have some questions that I will be posing to you guys. Just a moment. All right, so I will begin by asking the first question, which is, what aspects of drug development for spinal muscular atrophy excites you the most? And I would love to hear from both of you on this one. Dr. Arps, we will begin with you, if that's okay.
Sure, thank you. And thanks so much for having me. I appreciate the time to spend with all of you today. So what excites me about drug development and really speaking on behalf of Biogen, really unmet need of patients is what drives innovation in our minds. So constantly having that connection to MDA and to the patients in the community has really led the drive for Biogen to produce medicines that make a difference. So in SMA, that started with Spinraza, almost 9 years ago. And then we expanded our reach into the ALS community and brought the first drug for SOD1 ALS called Qalsody to market. And then just last year, we included a partnership with a company called Reata, who is now a part of Biogen, to bring a Friedreich ataxia drug to the market as well. So continuing to really observe what else is needed, where do we need to continue that innovation, is what's the most exciting part to me. And really hearing from and understanding the patients is the most important part to that innovation.
Yeah, absolutely. And also just seeing it expand to so many different neuromuscular diseases is very exciting. Mindy, do you have anything you would like to share on as far as the aspects of drug development that excite you the most?
I think Dr. Arps said it very well when she said that innovation comes from unmet need. And I am not going to tell you how old I am, but I am older than a lot of people in our community and have lived with spinal muscular atrophy for a long time. And what I will tell you, well, and I'm about to show all my cards because we know how long Spinraza has been out, but I lived about 44 years with there being absolutely nothing that anyone could do about this condition. And when Spinraza was announced and approved, it was my miracle, you know. And so I will say that, you know, being on the front lines and watching drug development happening and new therapies coming to the table all the time, anything that brings any kind of promise or hope, I find exciting. And the other thing that I'll say is, you know, being someone a little bit older who's living with this condition, you know, my muscles have had a bit more time to atrophy than a child. And so that is something that is really on my mind, and that I'm paying very close attention to, because once you have a certain amount of muscle loss and atrophy, it's hard to get that back. And so those are things that I really pay attention to and keep my ear to the ground for anything that's going to restore any function.
Yeah, absolutely. But yeah, what an exciting time to have seen so many advances, especially in the recent years. So
It's really exciting.
yeah, so thank you for sharing both of your input on that. Okay, so the next question we have is, what are the biggest challenges in drug development for SMA? We know we've seen some great things coming through the pipeline, but what are some of the biggest challenges that are being faced?
Yeah, I can start by speaking really from a drug development perspective. Some of the biggest challenges really are all the innovations coming at the same time. So that's a very good thing. We want that challenge for sure. And as Mindy said, it's just been amazing in SMA to watch over the last 9 years the expansion of research in a lot of different areas. But when you're in a rare disease or even a less rare disease, but physicians who are treating the same kinds of patients. So I'll use SMA and muscular dystrophy as an example. There's a lot of great innovation going on, but when it's happening in their clinic for lots of their patients, it gets hard to make sure that the offices that do the research and care for the patients have enough resources. Do they have enough study nurses, time, office space in order to really work with all of the studies that might be going on? Do they have the right patients? Are their patients already in studies? So it's great to have so much innovation, but it put a burden on the way that our healthcare systems work. And our experts who are busy taking care of all the patients and also doing the research have to really be thoughtful about what they can actually take on. And I know that makes them feel a little frustrated sometimes because they want to bring it all to their patients. But I would say that's one of the biggest challenges we have right now is bringing things in a timely way, but not necessarily always having the right resources for the doctors and the patients who contribute to that research.
Yeah, no, and that makes sense. I mean, that not necessarily something that everyone thinks about, but that makes perfect sense and how that would be difficult. And I don't know, Minzy, if you have anything you want to chime in with this one. If not, we can move on to the next. But
Let's go ahead and move on. I think she got it very well.
that sounds great. Thank you. Okay, so where do you see the treatment for SMA going in the next 5 years? Dr. Hack, I'll let you take that one.
Sure, sure. So, as a clinician and a researcher, it's amazing to look back at how far back in what we call the pipeline there is innovation and new ideas coming, which is great. That means even things that could be coming in the next 2 years are not the end. We'll continue to look for those possibilities in SMA. And so our focus at Biogen has been really across 3 different spaces. So number one, with having Spinraza approved in many, many countries around the world and available for patients, we continue to want to study Spinraza to find out if the 12 milligram dose works in all patients, if there's a different safety parameter. We're looking at research to say now with other therapies, what happens if you use Spinraza after another therapy in SMA? Is that safe, first of all? Does that change the outcome for the patient? So it's important to keep studying the drugs that we bring to market. We don't just get them out there and walk away. The second focus area is patient experience. So we know, for example, the drugs in SMA today are given to patients in completely different ways. And sometimes those are good for patients and other times they can be a bit of a burden. So wanting to always focus on that patient experience. Is there a different way we can administer a drug that's easier for the patient, that's safer maybe for the patient? Are there devices that could be used that help the patient get the drug in a more comfortable way? And then the third way is really the innovation. So how do we look at new molecules that meet an unmet need? Are they better? Do they last longer? Do patients have to take them less frequently? So really looking to the future is around that, continuing to study what we bring to market, maybe studying a different dose of it if possible, really trying to find ways to improve the patient experience. And then finally, really going out there and looking at that innovation to say, what molecules are the PhDs in the labs finding that we want to be able to try safely in patients to try to find new and better therapies that extend the quality of life even more.
Absolutely. Again, it's an exciting time. Mindy, so flipping to the other side of things, what are your hopes in treatment in the next 5 years? I know you had mentioned, some muscle atrophy and different things. So I would love to hear your perspective on the next 5 years of treatment.
Yeah, absolutely. I think that, I'm excited to hear everything that Dr. Heck just said, because, as a member of this community and a person living with spinal muscular atrophy, I am looking for anything that anyone can do for me. And so, what I think that everything that was just mentioned are all of those critical things. It's, what are the innovations? What are the new therapies that might not be available yet? Are there combinations of therapies that I can be taking? Are there different doses that are going to be more effective for me than maybe for a 2 or 3 year old? And so all of those things are things, again, that occur to me and that I wonder on a daily basis. And I know that people are working on those things, and those all give me hope, and I think that the other thing, just that I would mention, and this is, I think, in response to a couple of the questions that have been asked here, the other thing is, it's tacky to talk about money, but drug therapy is not inexpensive to develop. And so I think that we all know that. And so that's, I think, another piece of the equation that we have to all be thinking through. And MDA's advocacy team is incredible in terms of looking for ways to incentivize companies and promote legislation and things that are going to really create progress for the rare disease space and make therapies easier and more attainable to create. So that's, I think, the other thing that is just sort of on my mind is, as expensive as these drugs are to make, how can we make them more accessible?
Yeah, I think that's a great point. An excellent point. So thank you both for sharing on that question. The following questions are focused a little more on the patient experience. So Mindy, it's kind of coming to you first on these next two questions. But what do you think the industry could do to make clinical trials more accessible for the SMA community? Do you think there's anything that could be done to make them more accessible?
I love that question, and I would love for clinical trials to be more accessible. I am about as far from being a scientist as you could possibly get. But what I do know is that I know that drug trials are very sophisticated, and they're thought through in a lot of detail and ways that we probably don't even know about. And so they have to be very specific and all of those things. But I will say that that again, as someone living with this disease, any opportunity that I have to try something that could that could improve the condition that I'm living with and improve other people's lives, I would jump at the chance to participate in a clinical trial. And so one of the things that I know that I've personally seen is, age ranges that are included in clinical trials. And again, I know that when you're studying a 2-year-old versus when you're studying a 65-year-old, which I am not, by the way, it's a very different person and physiology that you're looking at. But that said, I would love to see some creative ways for clinical trials to be structured. Maybe it's the endpoints that you're looking at in clinical trials. Maybe there are multiple endpoints. Maybe it's a matter of testing various populations at the same time with different endpoints. I certainly don't know what all the answers are, but as someone who is looking regularly for ways to try new things and get involved, I would love for there to be some additional, creative options out there for ways to bring clinical trials to the community.
Yeah, absolutely. I think those are all very, very valid points. Thank you for sharing. And then the other question I have for you, Mindy, is what would you like for pharma to know about living with SMA?
Oh, I
In
thought
a
about this
very
question
quick little nutshell.
Yeah, I thought about this question ahead of time, and I think that it's such a scientific field, and anytime you can insert that human experience and that personal story into what they do every day, and they're looking at the data and the numbers and right, that's exactly what they should be looking at. But SMA is it's like, I mean, we all know what it feels like to live in our bodies, and there's no getting away from your body. There's no escaping your body. And so the fatigue that you feel every day, it's almost like having 50-pound or 75-pound weights strapped to your arms and your legs every minute of every day. And it's a difficult thing to talk about, but I hope that sort of underscores the urgency that all of us in the community feel, because like I said, every minute of every day, that's what it feels like. And if you try to imagine brushing your teeth or eating a meal or fixing your hair, getting dressed, all of those things with 75 pounds of weights strapped to your arms and legs, it's a challenge, to say the least. And I don't think there are quite the words. I don't think words have been invented yet to explain exactly what it feels like. But that, and then knowing that on top of that, it's progressing every day. And maybe that 75-pound weight is going to become a 100-pound weight. And other health issues and things that come up by extension that are frightening. Those are all of the points of urgency that I'm grateful for the opportunity to share.
Yeah, and that was very eloquently said. And there, you're right. I'm sure there aren't words yet, but you just did a wonderful job of explaining it to the best of the ability. So thank you so much. Kind of switching gears, kind of back a little bit to the industry side of things. Or I'm sorry, how can we get more patients with SMA access to the drugs in development? It's kind of touching back on what we've already touched on a bit, but how can we get more patients with SMA access to the drugs that are in development? And Dr. Hack, I'll let you take that one.
Sure. So first of all, thank you, Mindy, for your comments. I think it's always fantastic for those of us on the pharma side and the research side to hear exactly what it's like to be, in your experience. And I appreciate your analogies. Those are great things for me to take back to our team, and I will do that. I think, some of the things that can help patients get involved now has really advanced with technology. So our ability to show what studies are going on, for MDA to provide education about clinical trials, for other organizations to help advertise, to use AI to help patients look for, show me a clinical trial in SMA. There's a lot easier way than just going to clinicaltrials.gov, which can be a little intimidating to try to understand. So I always appreciate that organizations like MDA are providing that education. I think the other thing that people sometimes forget is every care partner, every HCP, healthcare provider that you see is a great resource for you. So many physical therapists in SMA and in muscular dystrophy areas are also doing research. Either they're part of the clinical trials on the drugs because they do the motor function assessments, or they're doing their own studies on new and better motor function assessments for different kinds of patients. The nurses that you meet up with, a lot of times they're also the study coordinators. So if you're interested in research in any area of the disease that you're living with, asking literally any of the healthcare providers that you talk to will help you get access to different things. Orthopedists are using different braces and devices, and sometimes you can be a part of those trials too, which might not be a drug, but you can still contribute, and that's important information. The last thing I'll mention is just directly having the drug companies and the researchers talking to the patients. So we like to host ad boards or roundtables around the drug development area to make sure we hear exactly what Mindy is talking about today, about trying to brush your hair with that heavy weight, or what it feels like, because that helps us all think about different patient-reported outcomes beyond what the FDA might require to do in a research setting in order to prove that a drug is safe and efficacious. We can try to build in those patient-reported outcomes that are meaningful to you. So those types of opportunities, we're very thankful that MDA can help us with those to make sure we get the right patients at the right time to give that really, really good advice we need to serve you better.
Yeah, and I love that you touched on the point of so many different ways to get involved in research beyond just the clinical trials, that there are so many different avenues to go, and they're all important in their own right. So thank you for bringing that to light. Okay, so our final question for our drug development roundtable session is it's a format. It's for you, Dr. Hack. It's, what are you doing to get patients and families more involved in the drug development process?
Sure, I touched on it briefly, but there's really a couple of things that we do. But the first is really to involve patients and their families, or parents, if it's for younger SMA patients, involve them in those roundtable discussions about what we're thinking about doing in our research. How will that meet their needs? Where are we missing the mark? What else might be of interest to people, so that we can really understand, where that unmet need is to try to help move that innovation forward. So that's a really very structured but super important way, and we depend on organizations like MDA to help us work appropriately with patients to get that kinds of information. I think the other part of it too is in forums like this, where we're able to hear directly from patients, and very eloquent ones like Mindy, who can talk about, desire to be involved and what they face every single day. Getting that into your healthcare providers, that's a great way for them to share it as well. We have medical people who go out in the field and work with our researchers. So anytime they can be gathering those insights about what matters to patients, we bring those back into Biogen and into the research environment to build into our studies.
Very good to know. And Mindy, I just wanted to give you an opportunity to respond at all to either of those last two questions that I asked, if you have anything you would like to add.
Thank you. Yeah, I think that there are probably a lot of people, it's hard to speak for as large a community as this is, but I think there are a lot of people that would agree with me that there is such a desire to be involved. And we've talked so much about this today. And so I love hearing from Dr. Hack about all of the efforts and things that are happening behind the scenes to try to involve the population that they're trying to serve in different ways. There's it's something that I hear all the time, again, in the advocacy world, that the saying is nothing for us without us. And I think that it's such an important perspective because we can maybe think of what hasn't been thought of or share, like you said, Dr. Hack, the life experiences and some things that might seem really, really small that we come up against every single day that might make all the difference in the way that you evaluate something. So I think that that's really the only thing that I wanted to add is just how much I know the community wants to be involved in, in solving the problems and coming up with the solutions.
Yeah, no, that's an excellent point. Thank you both so much for sharing your time and your expertise with us for this drug development roundtable. We were very grateful to have you, Mindy, and you, Dr. Hack, to be able to discuss, and answer these questions together today. So I appreciate both of your time. Thank you so much.
Thank you for having me.
All right, so just kind of wrapping things up. I wanted to, excuse me, sorry, if you are new to MDA and have been diagnosed with a neuromuscular disease under MDA's umbrella, or if you are a loved one or someone who is diagnosed, we encourage you to stay engaged with us at MDA. You can do this by visiting mda.org/join and completing a short form. Joining is free and will keep you up to date on the latest research, educational programs, and supports. We would also like to again thank our sponsors, Genentech, Biogen, and Scholar Rock for supporting MDA's SMA virtual learning series and Q&A session. And then before we go, I wanted to highlight a few of the upcoming MDA community education events that may interest you. You can learn more about these events by visiting our website or by scanning the QR code on your screen or clicking the link in the chat box. MDA will be hosting 4 in-person MDA Engaged symposiums across the country. Join us for these half-day multi-session programs with both disease-specific learning and general learning sessions that are applicable to all neuromuscular diseases. These events are free to the MDA community and will be located in Atlanta, Georgia, Dallas, Texas, Irvine, California, and Palo Alto, California. And finally, your feedback is important to us. So please take the survey at the end of this webinar. I will actually be sending it out separately due to the situation with the beginning of the webinar. So be watching your emails for that survey to come through. Completing the survey will provide us with important insight as we plan future educational programs. If anyone has any questions after this webinar, please feel free to contact MDA's Resource Center at 1-833-ASK-MDA1. This concludes today's webinar, and we hope to see you again soon.